Hi, everyone. It's very hard to follow the pioneers in this field. Trying to change, okay, to this. Now it's better, okay, good. So I'm just gonna go to the basics, honestly, with the robotic bronchoscopy platforms. And what I'll focus on is really as, it's still going on? Okay. Just, where's it up there? I can, it's not showing on my, yeah, it's not showing on my screen here, that's why. Yeah, it's working better this way. Thank you. Sorry for the delay. And we will talk more about the basics of the robotic bronchoscopy. This is our weather here, and back Chicago is like we're expecting a snowstorm today, which is what we'll get tomorrow most likely. And I will focus more on the how you do your daily work with the platform in general. And the difference between the using that bronchoscopes with the robots is now you have more control with more console, that you don't have to hold the scope in the right spot all the time in case you have any diversions or movement. And that goes all to the shape sensing, and Mike covered that very well, but you can understand now from this how the shape sensing catheter covering and move through the airway and give you data within 1 second, 100 signals to tell where exactly the catheter is. And that's in 3 dimensions, which is give you the chance to really localize exactly where the catheter is with registration, and then after that with the case. Of course, that gives you the space while they're doing the procedure, and the diversion will be still there between the CAT scan that you plan the case with. So we start the day always with registration, and registration is using another computer, as you see here. You can pick the target. When you localize the target, then you create a pathway. And when you create the pathway for the lesion, that gives you the graph that we saw it multiple times today, including the path that you're going after. Also, you can see the borders, the anatomic borders with the pleura. That gives you some confidence that at least you know how far you're going in the airway and how to prevent complications. And also, you can do, as Amir mentioned earlier, that to get a muscle memory, to know where exactly your path going, in case something happened, at least you have a backup plan to go with even thin scope or even whatever other platform you can use to get to that area. So always it's good to review those information prior to the procedure. And this is a quick video showing how a day starts with a setup. All the instructions come from the robot itself. If you open the screen and put it on, then the steps shows up. And I will put very quick here the steps that come up, connecting the catheter connector first, and then advancing to putting that catheter connector on the machine. And then it will give you the next instructions, which is putting the catheter in the right spot and connect it to the arm. Those have 5-time life use. So those you use them for 5 cases usually, and after that you can, it's not usable. Of course, there's a cleaning of those specific connection points, and then the catheter will do the calibration, which is a very important part of the procedure because you want to make sure that this is happening prior to establishing the drive that give you the 3D sensing shapes that created by that catheter. And after that, everything will be ready to proceed, and connecting the vision probe at the end, and with that, this setup already done prior to the procedure, of course. Very important, as highlighted multiple times, to have an idea about what to tell the anesthesia and connect with them before the procedure. You don't want to do all those steps and then the anesthesia that doesn't know what you are planning to do. And highlighted in different setup before, but this is a picture that you can see that we look for FiO2 40%, PEEP between 8 to 12, tidal volumes in the higher part, like between 6 to 8 or 10 ml per kg, ideal body weight, and also we request TIVA and full paralytic agent through the procedure. And then you have the docking, when you put the docking with the ET tube, and then you put the catheter in, and that time you start. So with that, I can start with the cases now, for example, using only the radial EBUS with the first. And this is a case of radial EBUS when you have something far in the lung and central, but large enough that you don't need really 3D imaging. And you can see from driving, as we see it multiple times, after doing multiple cases, your driving will be much easier getting to the lesion. And with this size of lesions, usually, you really see an endobronchial lesion. And you can see it even visually matching your area. And here you can see the tumor blocking that bronchus. Now, I know that from parking there, the catheter will not move anywhere. And then also confirming with radial EBUS sometimes just to show you that we are concentric, and collecting the samples from there that can help. Why I re-emphasize on the anesthesia part, because this is an example where the anesthesia machine unfortunately failed when we were doing the induction, and the circuit has a leak, and we have to bag the patient for 10 minutes. And the atelectasis is formed, and now we are going after 10 millimeter lung nodule, but unfortunately now it's sitting in the shadow, and even with the radial EBUS is very confusing. So that's where the importance of, even if you have a real-time imaging, and this time we have the O-arm in this situation, it's very hard to localize your nodule, and we have to put the CAT scan next to this image and make assumption where the nodule is to get to it. 3D portable imaging, one of them is the O-arm, and this is like a platform that most of the hospital has it, and it's very important, as you see from this picture, to know where you are setting up your O-arm with the patient. Because the height of the bed is very important to start with the level where you can adjust the O-arm up and down, and the movement in and out also for the clearance is important to start with any case with the O-arm with these cases. The other form is SIOS spin, which is a 3D also form. This is an example of using the SIOS spin for a patient who has multiple comorbidities with also has a 9 millimeter lung nodule in the left upper lobe where the ICD is sitting, and IR also was not able to get a safe access to it. Using the robot, you can see now there's a reach there, but because I know this patient that even with getting a signal with the radial that was more eccentric, as you see here, it was very important that we need to get an answer for this patient. And for that reason, we did the spin to see if there is any adjustment, because we know we are next to the lesion, but we are not concentric. And doing the spin, as you see here, take around 30 seconds to get all the information. But after that, we analyze the data. And this is before the integration with the SIOS with ion. And you can see from this, the radial EBUS is sitting superior to the nodule. So moving the catheter more inferior and adjusting the target, updating the target also. So we know where the previous target is and now where is the new target. And confirming again with radial EBUS, you can see that we are now more concentric, and we got the sample from that area that shows adenocarcinoma. And in this case, because we know that most likely the patient will be, he's not a surgical candidate, a fiducial placed just for help with the SBRT in the future treatment. The other advantage of using those real-time imaging is that you can see that, as mentioned in previous talks also, that we can sample both lungs. And not only for confirmation of the location of the lesions, but also to help us rule out any pneumothorax with the first side before moving to the second side. And this is a lady that had 2 lung nodules that, with a history of breast cancer, squamous cell carcinoma, and adenocarcinoma. And by performing the O-arm, you can see we got a view that we are in the lesion, and also the radial EBUS confirmed that we are in that 8 millimeter nodule on the left upper lobe. Sample done, and then we moved at the same time to the other side. And within like 40 minutes, we got both sides sampled. And that side is more ground glass, but those cases shows one of side was squamous cell, the other one came back as adenocarcinoma. And that's the importance of doing sometimes the procedure at the same time for both, where now we feel more confident, especially ruling out the pneumothorax in the spot. Ground glass opacity, another indication for using the real-time imaging. And this case also a patient that has this growth, very slow, of lung nodule, which is more ground glass with some central solid part. Also using the O-arm, which is 13-second spin, you can see that our tool inside the lesion. Even putting radial EBUS in this case will not give us a good signal. So sampling without having real-time imaging where you are will be tough. And getting the sample, as you see here, after we did the spin and confirmed that we are on the lesion, gave us the answer with more granuloma on one side, but the other side was lipidic adenocarcinoma. And this is sometimes in the past, we used to see granuloma changes before we see the real tumor. And for the last case also now, for more accuracy for the segment removal, combining same-day anesthesia for those cases, which we'll talk in details later in the day. Here, a case where you have the XI da Vinci and the ion in the same room, starting in the morning first with labeling. You can see here, because of the delayed anesthesia, we created some atelectasis, but our target was more central but more apical. And confirming with the location with the tool in target, the ICG were socked over the fiducial that inside the tube over there, and then that fiducial coil advanced to that area where the lesion is. And after putting the fiducial, placing it, repeating the spin, we confirmed that the fiducial adjacent and in the, or almost in the lesion, but not touching the pleura, and with the flushing 2 cc of saline and then also some air over the fiducial, with changing and when turning the patient and go for the surgery, you can see here the with the firefly light, that segment is really very clear where the lesion is, and there where the surgery done. So with summary about the talk, we have pros and cons, of course. It's not like, it's still an expensive technology. It has its own learning curve, but also by getting the training happen and you have the staff trained, the flow will be faster. The second thing is, still we dependent on combined with real-time imaging for some difficult cases, ground glass opacity, bilateral lesions, 8 millimeters. There's cases that you don't have a bronchial sign, but also concerning at the same time with the too much radiation use for those cases. Also, we have to keep in mind that we have double-edged sword in those cases. With that, I come to the end of the talk, and thank you for the attendance.